Although the PowerPoints presented here are from Lippincott-Taylor's fundamentals, this is also to be used for Nursing 102's version of fundamentals with Wilkinson. So, healthcare of the older adult. It is projected that in the year 2050, there will be 1.53 billion people on Earth. Of that total, 29 million of them will be 65 and older. In 2030, 71.5 million people will be 65 and older. In this country, the United States, it is projected that those who are 85 and older will increase in numbers from 5.3 million people in 2006 to a total of 21 million in 2030. Due to this graying of America, healthcare costs will increase by 25% in 2030. It can therefore be inferred that much of the nursing care given by those in this class will affect those who are 65 and older in the upcoming years. With this knowledge, we need to understand that nearly 88% of all older adults will have at least one chronic disease. Some of the more leading causes of death in older adults includes heart diseases, malignant neoplasms or cancer, cerebrovascular disease, COPD, which includes bronchitis, emphysema, also Alzheimer's and diabetes mellitus. Other leading causes of death in adults 65 years and older include pneumonia and influenza, nephritis, nephrotic syndrome, accidents, unintentional injuries, and septicemia or blood toxicity. The baby boomers, those American adults who were born from the years of 1946 to 1964, will make up the majority of those elderly adults. From 2011 to 2030, they will begin to enter their senior years. Nurses must prepare to deal with this generation of healthcare consumers who will have higher incomes, higher educations, and very active lifestyles as compared to those of previous generations. They will be better informed and will more likely seek health information on the internet prior to consulting their healthcare provider. As preventive healthcare, they will seek encouragement, community-based support services, and other efforts which will prolong lifelong health behaviors. So, as we look at the upcoming years and recognize that many of our healthcare consumers will be elderly, we should then focus on what physical, mental changes should we assume person faces as normal changes due to aging. When we look at cardiovascular changes, we should expect decreased cardiac output, a diminished ability to respond to stress, decreased heart rate, decreased stroke volume, slower heart recovery rate, but also an increased blood pressure. Some of the reasons for these changes: shortness of breath will be related to increased rigidity of the heart valves. Also, the heart valves will be thicker. We should expect this generation to have orthostatic hypotension, which is related to a decreased sensitivity of those pressure receptors, which are also called baroreceptors, that help to regulate our blood pressure as we change positions. So as they stand, blood pressure baroreceptors should increase the blood pressure. When the elderly have desensitized baroreceptors, this change in blood pressure does not occur rapidly, and so they sense a feeling of dizziness when switching from supine to standing. Other things that we may see or cardiovascular changes due to aging may be a pooling of blood in the extremities. Again, incompetent valves in the veins and a decreased ability for this blood pressure changes. We will see that whereas the heart rate may continue to be the same, more often it will slow because of a decreased heart muscle, but we will see the blood pressure increase, and this is related to two factors. Number one, there will be increased arterial resistance due to plaque, buildup of atherosclerosis in the arteries, but also the arteries will be less elastic based on having less tissue elastin in those arterial walls. In the respiratory system, we will see these changes. Residual volume will increase. Residual volume is that amount of air that stays in the lung during both inhalation and exhalation. This stale air then is unavailable for oxygen carbon dioxide exchange, and therefore diminishes the overall vital capacity of the lungs. The vital capacity is that amount of air that can be forcibly inhaled. Because the vital capacity will dwindle, this means that although the person may be able to talk and do those sedentary activities, when increased exercise demands more oxygen, their decreased vital capacity will not allow them to compensate for that demand. You will see decreased gas exchange, diffusing capacity, again, will not be able to take in as much oxygen, and the diaphragm, again, being a muscle, will not have as much elasticity, will not be able to contract as forcefully, and again, some of the alveoli may not have the same capillary surface space. Again, less oxygen being exchanged between the alveoli and the capillaries. Again, what we will see is a decrease for activity tolerance whenever activity becomes more prolonged. This person will experience fatigue. They will also overall have a lower vital capacity, less oxygen going to the tissues. On the integumentary system, the changes that we should see in the aging adult, decreased subcutaneous fat will lead to some feeling of chilling even in a warm environment, because that subcutaneous fat cushion will no longer be there to provide insulation against environmental factors. Decreased interstitial fluid will mean that the person is more prone to dehydration, so that this is the fluid, again, remember, that's between the cells. Decreased muscle tone, glandular activity. This person will be weaker. Their skin, glandular activity, they will have less sweat glands and less oil glands. And so with the sweat glands, less ability to regulate temperature when they get overheated. For oil glands, their skin will be drier and more prone to breakdown. Other things that we're going to see is decreased ability to protect themselves from sun exposure, more prone to sunburn, heat stroke. So for sunburn, we want to include an SPF factor of 15 for sunscreen. Remember, overexposure to the sun could make this elderly person more prone to cancer. Finally, capillary fragility. This will again predispose the elderly to skin impairment, especially the breakdown of skin capillaries related to pressure, which would lead to pressure ulcers. On the reproductive system, again, we expect that the lifestyle of those 65 and older in the upcoming years leading up to 2030, 2050 will be more active. So that we should not consider that these persons will not be sexually active. However, because of aging changes, the female may see some vaginal narrowing, decreased elasticity, and a decreased vaginal lubrication. Also, she may be able to have sexual arousal, but it may be more slowly developing. The decreased vaginal secretions may lead to some painful sexual intercourse. For males, may have decreased sperm production, but unlike females, they will be able to reproduce throughout life. However, they will also have a slower sexual response. Musculoskeletal system, this will be probably the most apparent change because of the changes in estrogen for females and testosterone for males. There will be more leaching of the calcium from the bones and going into the bloodstream. This will cause less bone density, and so more chance for those pathological fractures. Pathological fractures meaning that a bone can break when there should not be sufficient force to cause the break in a more dense bone. Also, because of osteoporosis, vertebra, the disc, will begin to degenerate in the back. And so you may see some loss of stature, definitely some postural changes. This could lead to some spinal changes such as kyphosis, which is commonly known as hunchback. Although this is more of a body image deterioration, it will also affect the size and the ability to expand the thoracic cavity, which could impair respiratory change. Overall, there will be some loss of muscle strength. I want to encourage my students to look up the handout on sarcopenia, which talks about these degeneration of muscle fibers. And so the elderly will be less able to react fast in activities, will be less able to repair muscles, and overall will feel weaker. In the GU system, genitourinary system, males may develop an enlarged prostate gland. This may impact their ability to control their urine. Also does have some impact on overall sexuality. I remember the prostate has a function in the creation of the ejaculatory fluid. For females, again, may notice more of a urinary incontinence. Again, this is due to weakened muscle support of the urinary bladder, and also a weakened sphincter for urinary control, primarily the detrusor muscle. Want to point out, though, that incontinence is not a normal part of aging. It may be the result of this muscle weakness, but remember, incontinence is a disease. Healthy adults 65 and older should not experience incontinence of urine or incontinence of feces, and muscles in the urinary system, as in all systems, can be strengthened through exercise. The GI system. Overall, let's talk first about difficulty swallowing food. This will place the 65-year-old and older adult at risk for aspiration. I want to remind them to modify the texture of food, but more importantly, to eat slower to prevent aspiration. Want to also look at having delayed esophageal and gastric emptying, so the stomach will empty slower, and overall, again, there will be a slower peristaltic motion. This could lead to that sense of indigestion, could lead to a prolonged sense of fullness, which could impact the overall appetite and might lead to anorexia, which eventually could lead to malnourishment. When we talk about delayed esophageal and gastric emptying, also reduced motility, have to think in terms of pharmacology, and so that medication will stay in the GI system longer, will therefore not be absorbed into the bloodstream as fast. And so I want to remember that some medication doses may have to be adjusted to compensate for this. Overall, there is a decrease in the digestive enzymes, and again, this impacts on the overall metabolism of nutrients, and this makes them less available for use by the tissues. Even though on this slide it talks about decreased sense of thirst, smell, and taste, I will address it here. This is part of the nervous system, primarily the sensory system. But if that person senses decreased taste for salt and sugar, may be more prone to having a decreased dietary intake, decreased sense of thirst. The body still needs these nutrients, still need fluid, and so again, sets them up for dehydration and for malnourishment. The nervous system, first, there is some deterioration of neurons, but again, we should remember that it should not be assumed that a normal part of aging is that the person will be less smart. Delirium, dementia, these are diseases. This is not a normal part of aging. And so although there may be a slower reaction time, the elderly person should be more practical in their decision making based on lifestyle experience, and so should not confuse delirium and dementia with a normal part of aging. Having said that, we will see as people age, there will be some noticing of dementia, primarily Alzheimer's, which is again a physical disease. This impacts the death of brain tissue, and so we should always assess for dementia, delirium, but we should also assess for depression, as the neurotransmitters serotonin and norepinephrine decrease in their production, this changes the chemical balance in the nervous system, and many times we see depression in this age group. So it should be assessed, and remember that depression can be treated with pharmacology, but it has to be assessed and reported, and usually nurses are the first line in making those assessments. The nervous system, we may also see some cerebral perfusion loss. This again leads to dizziness. It leads to orthostatic hypotension, and primarily the outcome is usually falls. We do note that many elders lose their mobility because of hip fractures that occur because of falls, and this seems to start a gradual decline. So we should make sure that as we assess the homes of the elderly, we want to put in place those fall precautions. We want to encourage our elderly to wear non-skid shoes. We want to discourage the use of throw rugs, especially those with no traction on the back, because this leads to slipping and falling. We want to encourage adequate lighting to prevent glare, and we also want to decrease the clutter in those walkways. Remember, as the vision diminishes, our elderly will be unlikely to notice something in their way. Also, with the neuromuscular decline, may have less coordination in their gait. So we want to do all those things that will prevent falls in this population. Again, vision, we want to look for diminished vision. So primarily here we're going to assess for cataracts. Cataracts are the becoming opacity of the lens. Remember, the lens is the actual part of the eye that allows us to focus the object onto that optic nerve, so that if the lens becomes cloudy, surgery is usually required in order to replace that faulty lens with an artificial lens. Other things we're going to see are presbyopia. Presbyopia, the lens does not accommodate to near and far. So we're going to see more farsightedness. People may have to use artificial lens in the form of bifocal glasses or some other type of eyeglasses in order to compensate for near vision losses. Presbycusis, remember, again has to do with aging and the loss of hearing those high frequency sounds. So again, we may have to recommend hearing aids, but more primarily, many healthcare workers should understand that if they speak in the low tone voices and avoid those high pitched voices, that you will not have to yell at your patients. Again, they'll just speak normally, but using those low pitched tones. If there is more of a hearing loss, remember that we can compensate by speaking in front of the patient so that they can see our mouth move. Again, using simple words, and then having to repeat our words. Don't change the wording. Use the same wording. Overall, again, we've talked about taste and smell, and primarily the loss of salty taste buds and the loss of sweet taste buds, again because of aging and the loss of those taste buds on the tongue, and this impacts the ability to smell and to taste and enjoy their food. All right, so we're not going to answer the questions here, but remember that one of the safety risks for those 65 and older is the fear of falling. Remember that we can avoid falls in the elderly, non-skid shoes, removing clutter, increasing the lighting, preventing the use of throw rugs, having assistive devices available also helps to prevent illness and injury from falls, but also remember that falls are the leading cause of death of those 65 and older. Okay, presbycusis, presbyopia, these are two age-related sensory changes. Presbycusis has to do with the lessening ability to hear those high-pitched tones, and again, remember, we can compensate for that by using the deeper voice and avoiding those high-pitched vocal tones. Presbyopia, this has to do with becoming more farsighted because of the lens not accommodating as when the individual was younger. This question talks about an age-related change in the body system. Decreased blood pressure. Remember, the blood pressure would go up because the ventricle would have to fight against arteries that were less likely to expand to accommodate blood, and the lumen would be narrower because of atherosclerotic plaques. Person would have decreased cardiac output. Remember, stroke volume is going to diminish and the heart rate will diminish. They would not have increased bone density. It would be just the opposite, and they would not have increased salivation. So the answer here would be B. Again, we've talked a little bit about depression and delirium, and we said that both of these are illnesses. They should not be linked with age-related changes. Depression does occur more commonly in old age, but it's primarily because of the loss of serotonin, which is a neurotransmitter, and there are drugs which can increase either the amount of serotonin or it can delay the neurons from absorbing serotonin as quickly, and so that it can stay around longer in the synapse, we will then see less depression. Delirium is a more short-term version of dementia, and so again, this is a confused state which we should assess for when we do a general survey, and we're looking for those mental status changes. Does the person know orientation to person, place, and time? But remember that delirium can come about because of food, because of drugs, and so delirium can be treated. Dementia is a more permanent confusion. Dementia, again, more permanent confusion. The most common form of dementia that we see is Alzheimer's. Also can be from vascular reasons. Remember, vascularity has to do with those plaques in the arteries, and also that decreased cardiac output. So if we're seeing less perfusion of blood to tissues, also will be less oxygen, and so the tissues will die. This includes the brain tissue, and so if we have that permanent death of brain tissue, we're going to see a permanent confusion, and this is called dementia. Okay, so this is true. Most common, maybe not true. A common affective mood disorder of old age, not necessarily Alzheimer's, more so depression. But remember that as we see dementia in old age, the most common cause of dementia is Alzheimer's. I would say the most common affective or mood disorder of old age would be depression. So, when we talk again about older adults, remember again, we're looking at an increasing population, and this is predicted that as we get closer to 2030 and 2050, more of our patients will be 65 and older. The field of geriatrics is that medical field that looks at those diseases of those who are 65 and older. The overall word of gerontological or gerontology is just the science of studying all things that are related to those who are older. So again, for nursing management, and remember, the reason we're focusing on aging is that we predict that most of our patients, as we stay in nursing, will begin to reflect these older ages of 65 and older. These are the things that are going to be most prevalent as their needs. We're going to have to support their thinking function. Remember, do not believe that aging means that they are going to naturally have dementia or delirium. But we will see some dementia in this area. Remember that as the neurons do start to diminish, we will have to do more supporting to keep these neural pathways open. But that will be something that nursing can help us to do. We want to promote physical safety, again preventing falls, which is the highest safety risk and also the leading cause of accidental death in the elderly. Non-skid shoes, removing those throw rugs, preventing clutter, having adequate lighting. Promoting independence and self-care activities. Remember that decline in musculoskeletal and some sensory deprivation may lead to some isolation because this person is no longer able to independently do those ADLs. Remember, as nurses, we want to support them in their ADLs, but we want to allow them and encourage them to do as much of their own self-care as possible. Reducing anxiety, agitation. Many of us will automatically think in terms of that patient with Alzheimer's as being agitated. But remember, anxiety comes as a result of loss. And so as we see the seniors who are 65 and older experience more loss of their family members or their friends, they're going to have more resultant grief. And part of grief will be that denial and anger and anxiety. Some of this anxiety will also be a result of the depression that comes from that change in the neurochemical balance in the brain, but also that sense of frustration and not being as strong as one used to be, of not being able to see as well as one used to do. And so this overall gradual decline in physical function may cause some anxiety, and so nurses are optimally placed to assist in filling in those gaps where the decline has occurred. Also, there will be this need for improved communication. So understand that social activity is still a major part of being human. Sexuality is still a major part. Being actively involved in one's religion and spiritual life. Being actively involved in the community. Even when one retires, remember again, want to avoid the stagnation, want to avoid the despair, those things that Erickson speaks of when we talk of middle age and elderly. Want to give more of this feeling of generativity, this more of ego integrity. providing for socialization. We talked about the sexuality needs, but more just, again, having to make new friends as they lose those people who are integral in their social relationships. Promoting adequate nutrition, which would be a problem as taste diminishes, smell diminishes, the ability to swallow diminishes, and this overall slowing down of peristaltic activity. So we want to make sure that our elderly have food that they like, that they are given more time to enjoy their food, and that maybe their meal times are less rigid so that they have ability to eat only when they're hungry. So rather than having large meals 3 times a day, may have to accommodate 4 to 5 smaller meals at alternate times. Promoting balanced activity and rest, again, because of that decreased cardiac output, decreased respiratory expansion of the thoracic cavity. They have to have more rest periods during activities. So that activities may need to be shorter and more evenly spaced. Also, ADL care, rather than doing a prolonged period of care, maybe we could break that up into smaller sections. Again, the final piece, supporting home and community-based care. Less than 4% of those who are 65 and older are expected to be in nursing homes or institutionalized care. And as we see the baby boomers enter this seniority, more and more of them will want to maintain their independence and remain in the community and in their own homes. And so nursing has to go and help them where they are. Pharmacological aspects, I think this will be the last piece we talk about. This word polypharmacy has to do with the multiplicity of drugs that many of our seniors are taking. Most of this comes from trying to compensate for those natural aging declines, but some of it also comes from self-medicating, so that people are taking vitamins, supplements, but also medication for indigestion and over-the-counter drugs for colds or constipation. As nurses, we want to make sure that they're reporting these self-care medications whenever they come into our clinic or our healthcare facilities. I also want to make sure that we coordinate because individuals may have several doctors. They have one doctor for their vision, one doctor for their medical care. Females may have another doctor for their reproductive needs. And so it needs to be a sharing among all of these healthcare providers of what medications are being prescribed. Medications need to be looked at, especially the dosage, to accommodate those changes in the GI system, in the renal system, and the liver system, and how we metabolize these drugs. Nursing implications for drug management. Start low, go slow. Again, we may need to have slower doses of medications because they will stay in the GI tract longer. They'll stay in the blood tract longer because the kidneys are going to lose those nephron units and will be less likely to excrete these toxic doses as readily as it did when the person was younger. We want to make sure that those who are in the home know which medications they're on and how to take them, and make sure that they are taking them as prescribed. We'll need to coordinate again among all those various doctors. If they're seeing an ophthalmologist, they're seeing a renal expert, they're seeing a family practitioner, they're seeing their gynecologists, all of these people need to know what drugs this patient is on, and if the patient is prescribing over-the-counter drugs, that also needs to be placed on a list. And that's the real recommendation, that there be one coordinated list, and this can be presented at each entry into the healthcare facility. Non-compliance for a medication we know is a problem. This one talks a little bit about keeping it simple, but what we realized is that most of this has to do with finances, that drugs are expensive, and that most people who are 65 and older will probably take as many as 14 to 18 drugs. There's going to be decreased income once the patient enters retirement, and so there becomes a question of, do I get my medications or do I get my food? And so nurses can be a change agent in accommodating both. All right, so these are some geriatric syndromes that nurses may be called upon to work with their patients on. Impaired mobility due to the nervous system changes, but more importantly due to the skeletal and musculoskeletal changes. Dizziness, orthostatic hypotension, falling, again, orthostatic hypotension, neuromuscular changes, urinary incontinence. Remember again, incontinence is a disease. It should not be accepted as a normal aging change, and so interventions can be done. Some of it has to do with just strengthening those muscle walls, also strengthening that detrusor muscle. Susceptibility to infection, we haven't really talked about this, but that atrophy of the thymus causes immunocompromise because of the inability to produce rapid new antibodies, and so we want to make sure that those vaccines for influenza, pneumococcus are always in place annually. And we want to make sure that the skin stays intact. Remember, that's going to be that number one defense against infection. Altered pain, febrile responses. Remember the diminishing touch because of those deteriorating nerve endings. So this patient may not feel pain. Remember, pain has that preventive function, that it lets us know that some things hurt the skin, or some organ is dysfunctional. And so this person may not feel pain, and so we need to do more assessing. But more importantly, we need to always assess pain. So remember that pain is that fifth vital sign, needs to be assessed anytime that we're interacting with a patient. Altered emotional impact, altered systemic response. Again, we've looked at the systems and those things that could change. Remember, with emotions, always think in terms of depression and always assess for depression. Some of the things that elderly will be faced with, again, once they retire, they may have less income, although we do believe that the baby boomers will be more economically stable than previous generations. But we want to encourage the use of social services. We want to look at Medicare and Medicaid. How do we help this generation to cover their health care costs, their medication costs, as well as their food and housing costs. We want to encourage home health care, keep this person in the home, and to maintain their independence as long as possible. If they are diagnosed with a terminal illness, we want to think in terms of hospice, which looks at not curing, but more importantly, to look at alleviating pain, alleviating suffering, treating those symptoms, again, which encourages dying with dignity, but more importantly, keeping that person in the home. And how do we age with a disability, which is more and more probably going to happen as we see the decline in new systems. Thank you. I've talked a lot about aging Overall, I want to encourage students to go back and look at the objectives for Module M on aging. There are some resources that are placed on Blackboard, primarily the chapter from Iggy, which is a medical surgical book that gives you more details on aging. Listen again to this integrity, and read up on sarcopenia. Thank you.